Good evening. Senior Care and Lifestyles welcomes you to join us this evening for the next 30 minutes. My guest tonight is Dr. Daniel Kaplan. Welcome.
Thank you.
And Dr. Kaplan is assistant professor at the College of New Jersey and is an adjunct professor at the College of Staten Island. A little bit of Dr. Kaplan's background. Dr. Kaplan has published 27 journal articles, and he currently has co-authored a book on strategies to cope with anxiety and depression, which is under review as we speak. And Dr. Kaplan's a proud father of 2 children, and his daughter Hadassah is here in the audience with us tonight. And welcome, Hadassah. So, Dr. Kaplan, we're happy to see you again. Glad you weren't afraid to come back. Tonight we're going to be discussing a disorder, and abbreviation-wise it's called SAD, S-A-D. So I'm going to leave it up to you to explain to our audience, what does this mean?
Sure. SAD stands for Seasonal Affective Disorder. And really what that is that a person's mood shifts as a function of a given season. Most people, when they think of seasonal affective disorder, they think of the winter, and I see in the title it's appropriately reflected that in the winter, many people become really depressed, sad, anxious, empty, irritable, feel like they don't want to get out of bed, they start to have difficulty concentrating, a lot of things like that. But it's actually called seasonal affective disorder. Many people do not know that there's something called the summer blues. So there's a second subtype of seasonal affective disorder where people can actually become sad in the summer. Another thing when we talk about the symptomology, it's important to understand that psychologists use the DSM, which is published by the American Psychiatric Association, and it's not listed as its own disorder. It's subsumed in mood disorders. So we would say a mood disorder with a seasonal pattern, basically.
Okay. Now, I grew up with the learning that my father would be not himself during the winter, and I somewhere read it was called light deprivation syndrome. Is that an old name?
Right. Actually, light deprivation syndrome is a synonym, so it's not a bad terminology. Like you said, when we think of seasonal affective disorder, predominantly we do think of the winter, and one of the factors that catches our attention is that there's less light in the atmosphere. The sun goes down earlier, and all of a sudden we get tired and sometimes even sad. But as I mentioned today, we prefer to call it a mood disorder with seasonal onset symptoms. That's what we would do.
Okay.
Yeah.
So now let's talk about who is at risk. My list is the seniors, baby boomers, elderly, and I just read today that this is the month where the first baby boomer was born, that they will be turning 70.
Wow.
So that group of baby boomers is 1946 to 1964. So the first baby boomer turned 70 on January 1st.
Wow.
So how is it for them?
So there's good news for people who, as we get older, our sleep cycles change. Now, I didn't have a chance to talk about some of the causes of seasonal affective disorder. One of the major issues is a change in our biological clock, which we refer to as circadian rhythms. When circadian rhythms change, that could result in changes in mood as well. These changes occur naturally as we get older as well. So it actually creates a buffer. So people who are younger are at greater risk, actually. So those people who are watching this at home, there's sort of some relief. There are other individuals that are at risk. We talk about female population, they're at greater risk. We talk about people with a family history of either mood disorder or seasonal affective disorder. And we talk about distance from the equator, which I know you're going to come back to. I do want to talk, because I ignored some of these factors, other causes, things like serotonin. In the brain, there are chemicals that we should know about. One of the chemicals in the brain is called serotonin, and that's responsible for sleep, wakefulness, but also mood. So if you think about seasonal affective disorder and the relationship between being really, really tired and being really, really depressed, there's some connection. And then there's also a third factor, which is a hormone called melatonin. And people sometimes will take melatonin supplements to help them sleep. So these are the factors that we should be mindful of as potential factors that drive these changes in mood.
Right. More and more you're seeing those two, it's the serotonin and melatonin, you're seeing them more and more in the journals, in articles that you get. And they're sold over the shelf, right off the shelf, no prescription.
Melatonin is an over-the-counter pill you could buy without a doctor's prescription.
That gives me cause for concern.
Right. It's cause for pause or cause for concern, because what prevents someone from self-medicating?
Right.
There are risk factors there. So yes, you can get melatonin straight off the shelf of CVS.
Yes, I know. I wonder about that.
Yeah.
But I think that if someone is like myself, you're reading an article, oh, I can't sleep, let me go try this. I don't think you would, take 5 times the amount.
I would hope
but
not.
you never know. People, well, if I take 1, maybe. If I take 5, for sure. Yeah, I think it should be monitored.
And that's something to talk about, because when you think about whether it should be monitored, whether it shouldn't be monitored, one of the greater risk factors for suicide is pill overdose. And that can occur in a couple ways. One is people forget, did they take their pill or not, as a person gets older. The other one is a willful choice. So your cause for concern is grounded in that regard. So maybe it should be monitored.
Well, in some way, or on the label, did you check with your physician for the dosage?
Yes.
I mean, I don't think that's too difficult. So just to review, you said between the baby boomers and the elderly, the younger generation is more apt to have this problem.
That's correct.
Right.
So as I mentioned, in terms of baby boomers versus younger generation, this is a bonus, because I don't know, I'm sure many people realize this, that as we get older, we sleep less. So we're naturally going to have these changes in circadian rhythms, and that actually creates a buffer. It's actually some exciting, it's an exciting concept in the research that we have a buffer against seasonal affective disorder, whereas a younger generation, not so much. Yeah.
Right. Now, excuse me, here's my question. Are the countries with 4 seasons more prone to having patients with SAD? Because in my mind, I'm thinking about, the summer, winter.
Sure.
What about people that don't have those 4 seasons, Alaska, Hawaii, whatever?
So we mentioned that the further you are from the equator, the greater risk you are. And it also ties into a point we said earlier, which was that it can occur in the summer and the winter. So let's see what I mean by that. So in the northern hemisphere, places that are the Nordic countries have greater risk of seasonal affective disorder. The Netherlands, greater risk. Northern Ireland, greater risk. Manchester, England, is very far from the equator. And the rates of seasonal affective disorder are off the charts. In fact, it's one of the rainy, cloudy nature is one of the risk factors why there's such a high suicide rate in Manchester, England. So that's the northern equator. And just to actually play a little bit of fun with this, let's take 2 states within the United States. You mentioned Alaska, and let's mention Florida. The research indicates that the rates of seasonal affective disorder in Florida are about 1.4%, whereas the rates in Alaska are something like 9.9%. So we're talking about a significant difference.
Yes.
And what's one of the prominent factors? Darkness. The other factor is distance from the equator. Now, that's our winter months. So you look at December, January, February, these are prime time for winter-based seasonal affective disorder. What about going south of the equator to places like Johannesburg, places in South Africa, Australia? The further you are on the other side, in the summer months, we also talk about distance from the equator once again and higher rates of seasonal affective disorder. I bet people from Ecuador think they won the lottery right now.
Yes, because Ecuador is on my mind, yes.
Yeah.
So it was kind of fun, you know, thinking about that.
Sure.
You know, and what popped into my mind right away was Alaska, you know, 6 months here, 6 months there. Yeah. So it's not on our list of questions, but how long have we been aware of this seasonal disorder? How long?
Seasonal affective disorder, the research, we started to discover it properly in the 80s, the 1980s. And there's a Dr. Rosenthal who wrote a book, I think it was in 1984. So we've known about seasonal affective disorder now something like 30 years. So, and we've developed some nice interventions, and I know we're going to talk about that as well.
Sure.
But we've definitely developed some interventions to address the problem.
Yeah, I was going to say, my father now is passed, but it was good 20, 25 years ago when he started talking to me.
Oh, yeah.
That he discovered it himself, is that he felt down, you know, he would never use the word depressed, but he felt down in the winter. And then what he started to do for himself is he would mark the calendar and he would count the days until spring. And that kind of gave him a little bit of hope and lift. Well, I only have, you know, 49 days left, and days are going to be longer and I can go fishing.
Right.
But he brought that to my attention, and I was not aware of it.
Yeah.
You know, I never heard of it before he told me.
I think that's a brilliant strategy that he used, and I do want to reflect on that actually, because one of the criteria in order to be diagnosed with seasonal affective disorder, it has to be multiple calendar years where the onset is roughly the same time.
Wow.
And the termination of the blues, so to speak, or sadness is roughly the same time. So him marking the calendar served a couple purposes. One, as a motivation that the spring is coming, but two, also it's sort of like a nice way of charting or getting a benchmark of when did I have that shift. I also feel a responsibility to say that just because it gets dark, we have a normal reaction, a release of melatonin as well when it gets dark. So even people who do not have seasonal affective disorder, when it's dark, when it's cloudy, we also get tired in winter. So there is an importance between separating when a person has a disorder and when a person doesn't. So I don't want people who hear this this conversation we're having to start to think that, hey, that's me. Because there are many people who naturally get more tired and sad because of melatonin being released naturally as well.
Yes, thank you.
Sure.
So now for our audience, like you just said, don't anybody panic, but if you've known that you become sad and depressed in the winter, if you're not your happy-go-lucky self, so what kind of a physician would they seek out to help them with this?
Right. So it's interesting that I would recommend speaking both to your primary care physician and a mental health professional, because here's where good coordination or good coordination of services or integration of services between a physician and a mental health practitioner can work, because your general practitioner or your primary care physician will do your physical exam and they could start trying to do an in-depth analysis on what's going on in the body. Maybe there's some underlying physical health problem that's going on, and it's not seasonal affective disorder. We have to rule that out. Another thing that the medical doctor can bring to the table are lab tests, right?
Correct.
So we want to get what's called a CBC, which is a complete blood count, which sort of checks the thyroid and many other endocrine functioning to see if the hormone levels are where they're supposed to be. I mentioned melatonin, which is one of the primary hormones we're going to look at. So that's the role of your primary care physician. If you have a mental health provider, you could also build that in. If not, if the primary care provider thinks that you could benefit, they can recommend you to see a mental health provider for a psychological evaluation. And between the primary care physician and the mental health provider, you can get a complete analysis to see if you really do have seasonal affective disorder.
Communication is so important between those two people.
Oh, yeah.
I'm seeing now, even for myself more than ever, one physician, a specialist, a neurologist, how he already has it set up with the primary care physician that they will share information, fax over the x-rays, the blood work, and then one physician will call the other. This is what she has, or this is what I'm working her up for.
You know, and that's a nice recommendation that there should, if you are seeing a primary care physician, a mental health provider, or even if you're not seeing a mental health provider, but you're seeing a primary care physician and a specialist, it's always important to consider that each doctor needs to communicate with one another. So release of information is very helpful to have on file, because otherwise, if you are one of my patients and we're doing psychological services, I can't share your information with your primary care physician without that release because of privacy laws. But if you put it on file, then if I need to share something, there's an open dialogue that can occur, and that's important.
Yeah, absolutely.
Sure.
So now we know what the symptoms are, and we know where we're going to go, and how are we going to be treated? How do you treat SAD?
So seasonal affective disorder, there's some traditional treatments, and there's a really cool treatment. And the really cool treatment I'd like to talk to you about first, and it's simple. It's called light therapy. And you could go to Costco. You could go to many of these places, and in the winter they sell what's called a light box. And a light box is, it's really remarkable. It's a small box, and it mimics sunlight, because what's happening with seasonal affective disorder is that you're not getting enough light. You're not getting the cues that you're supposed to be alert, wakeful, and upbeat. So this light box mimics the sun, and then it actually, within a few weeks, will lift your mood, believe it or not. So here you are. You could take 30 minutes, have your bowl of cereal, read your newspaper, have your light box going, and it will actually lift your mood within a few weeks. That's amazing. Now, just a practical piece of advice, if a person is going to use a light box or light therapy, speak to your doctor first, because some are better than others, and I don't have a brand name that I can recommend for you, but there are certain boxes that work better than others, and your primary care physician would know better which one would work best for you. So that's one intervention. Another intervention is more of a traditional intervention, medication-based. So seasonal affective disorder is absorbed or subsumed into what's called a mood disorder. So a lot of the medications that we would use for a mood disorder are equally relevant here. So I put some notes down here. Wellbutrin. Wellbutrin is an antidepressant. It works wonderfully for seasonal affective disorder. And there is another class of drugs called SSRIs, which are selective serotonin reuptake inhibitors. These are probably the best drugs we have for depression. Things like Lexapro or whatnot could be very helpful. And then aside from the light box and the medication, there's standard psychotherapy. if the underlying issue is a mood-based condition, using cognitive behavioral techniques, working on irrational thoughts, working on re-engaging in certain behaviors that you may have stopped, that could be very useful in improving your mood. So psychotherapy would be the third one. So the light box, medication, psychotherapy, in no particular order.
Right. I've read about the light box, but I would think you need guidance on that because, like I say, there are so many different types of lights. In the back of my head is a little voice. I read about nursing profession, working nights, pitch black outside, the fluorescent lights at the desk, but the whole hall is dark. I can't remember, you know, the whole crux of the situation, but I can definitely see the difference between working the night shift and working the day shift. And I'm guessing that has to do with the amount of light, I'm guessing.
Yeah. So without doing a role reversal, your experience was that people who work at night have more mood changes than people who work during the day?
Yes.
So yeah, what's going on there is that, again, circadian rhythms. We're supposed to be awake at a certain point. We're supposed to be asleep at a certain point of the day. If you're working at night, you're flipping your circadian rhythms, which are going to put you at risk of seasonal affective disorder. So one, you're waking up, it's already dark when you're starting to get ready for the night shift, perhaps. And two, the idea of flipping your circadian rhythms or your sleep and wakeful schedule can interfere. So yeah, so it's twofold in my opinion.
Right, and the philosophy is in the hospital is to keep it dark for the patient's benefit.
Right.
We used to have lights on, but the patients, you know, they think it's daytime, they're out there all, and what happens is you forget that it's nighttime, so you're talking in a normal voice. But we have the lights off for the patient's comfort. You go in the room, the lights are off, and I just kind of hooked that up in my mind with, I wonder.
That's a wonderful connection. There's no reason to think that that's incorrect.
Somebody should do a study on that. I did read many times about nursing department, police department, fire department, those that do they call it the shift work, the night shift. The length of their lives are shortened, in addition to everything else that happens to you when you flip your body.
Sure.
I happen to be a night worker my whole entire career, and I adjusted it very well. Went home, went to bed immediately, slept a couple of hours, and then up. But I have come across nurses or nursing, you know, auxiliary nursing. They're there for a week, a day, a month, and they just cannot adjust. They can't do it.
100%. And part of that, when you think about it, is if you work nights all the time, then it'll probably be fine for you. But let's say you're a nurse and you work 3 12-hour shifts. And then the other 4 days, you go back to your day schedule. Right? So you go shopping, you do this, you do that, and your day schedule is different from your night schedule. It's going to be hard to transition. So the more you can keep your, so to speak, your nights, your days, all 7 days of the week, the better you're going to be. But it's quite an uphill battle because you're fighting the brain's cues, which tell you, now's the time I'm supposed to be in bed. It's dark, it's quiet. These are the cues that tell me it's time to start resting. And you're fighting against it. And the more contradictory messages you give your brain, the more likely you're going to have a struggle.
Yes, some people have more struggle than others. So our last question, I think, for this evening, is there a way that we can prevent it, deter it, delay it? What can the future seniors, baby boomers, what can they do? Anything at all?
Well, I have some practical recommendations. The first thing you could do is make your environment sunnier and brighter. Something simple. Even if it's cloudy, open your blinds. Let some natural light come in. And that natural light actually has a similar effect as a light box or the sun, obviously, and allow that to occur. So you want to have your blinds up. You want to have sun coming in as much as possible. And if you work in an office, do the same thing. One of the hardest things in an office is if it's like 4 walls and no windows.
Right.
That's going to be harder. But if you have a window, there's no reason for you to draw your blinds and keep it dark. So that's one thing you could do. And if people at home are listening, there's no reason why you can't open your blinds. That's one thing. Another thing is go outside. Even though it's cold, even though it could be cloudy or overcast, it's still outside. The sun can penetrate the clouds. There's nothing wrong with it. You could go out, you could take a walk. That helps with the heart and whatnot. You could eat lunch in a nearby park and get some natural sunlight. And all of these things can help. And I know it's cold and people don't want to be outside in the cold, but getting outside is helpful. A third point is exercise. Exercise is a natural buffer against depression. When we exercise, what happens is our body produces these things which are called natural painkillers, endorphins and cathalons.
Right.
And they give us a similar experience as if we were on a drug because they're internal opiates, they're internal painkillers, but they also give us a high.
Yes.
And this internal high of exercise can make us feel much better. Aside from that, there are mind-body techniques. Consider things like yoga, meditation, massage therapy. A lot of these self-care exercises are fantastic. A couple years ago, went to a conference about the power of yoga, power of meditation. And it wasn't on depression, it was more on like retaining memory and cognitive decline. And what the researchers found was that long-term yoga, yogis is what they call it, or people who engage in meditation, their brains were more intact, they had fewer cognitive deficits. So things like yoga, meditation, massage therapy are all fantastic things that could help uplift the mood as well.
Yeah.
So these are some of my thoughts.
The first time I went to formal exercise, I went to, it was called Lovely Lady, and I couldn't get over the fact that when I finished and I left there, I felt so different.
Oh, yeah.
I didn't use the term high, but you're correct,
Yep.
because it is like a natural high. I felt great after I did that kind of exercise. It was wonderful.
And it helps the heart, it helps the body, it helps with everything. Yeah.
Our time has flown by, so we have to
Wow.
say good night.
Oh my goodness.
And we're going to have you back again for our
Please do.
next discussion.
Okay.
Thank you so much. Thank
My
you for
pleasure.
coming. And to my
Thank you very
audience,
much.
good night.